guys, so we have a very exciting announcement about a new way of approaching your residency learning goals.
We have teamed up with a group of really passionate individuals to try and completely reshape what we do at the podcast and turn it into a long curriculum. And we're calling this GOALS, the OBGYN goals to be specific.
Yes, so this stands for Gynecology and Obstetrics Adaptive Learning System, and it's going to be located at obgyngoals.org. What this is going to be a new standardized open source OBGYN residency curriculum that focuses on the CREOG learning objectives.
Sign up for an account, which by the way is completely free. And then on your member page, you'll be able to access the curriculum where once a week we will upload a new lesson that provides you podcasts from the past, provides you visual and other types of summaries, videos. And then you also can click through and test yourself using cases that are oral board style cases, multiple choice questions, and then find deeper reads on the subject, sourcing from textbooks that you use as well as from current literature.
So sign up now at obgyngoals.org. This is going to be a great new way to study for wards, for your CREOG exams, and of course, your boards.
Faye, it feels really nice to be back and recording podcasts again after parental leave. But, even 6 weeks later, I feel like I have missed a whole world of things in OBGYN.
Yeah, me too, especially 9 weeks out. But thankfully for us, we can refresh our memory with the OBG project.
That's right. The OBG project kind of has their great summaries in these bullet point formats online. They've got resident exclusive resources, the core curriculum, and they've got a new project in the primary care med project. You can check that out as well, which lets you get up to date with all those primary care guidelines that we got to keep up with too.
And even better, if you're a resident, remember that you can get OBG first absolutely free. So if you want to figure out how to do that, go ahead and go onto our website, click on the sidebar, and link to the OBG project. All right, guys, welcome back. This is Faye.
This is Nick.
And this is CREOGs over coffee. All right, Nick. So today we are back with another, I would say, more high-risk OB topic. But today we're going to talk about chronic kidney disease in pregnancy. So what are our learning objectives for today?
Totally. So first, we're going to talk about identifying patients with chronic kidney disease prior to and during pregnancy. Then we'll discuss the management of kidney disease in those time periods prior to and during pregnancy. And then finally, we'll talk about the counseling of patients with chronic kidney disease, specifically on pregnancy and delivery outcomes. Faye, I think one thing that I certainly have been surprised about as just a preface to this topic on kidney disease is maybe once upon a time I thought that this was something that was really just in the realm of internal medicine and older folks and rounding with nephrology for hours and hours on end. But it actually seems to be more common than you would think amongst a population of reproductive age individuals.
Yeah, absolutely. So, chronic kidney disease actually affects many patients of childbearing age. So if we're thinking about, I would say the ages of 20 to 39, certainly I think nowadays the childbearing age is outside of the window. But if we're just looking at the ages of 20 to 39, in these individuals, stage 1 to 2 or normal or mild renal impairment actually affects up to 3% of our patient population in this age range. And stage 3 to 5 actually affect 1 in 150 patients in this age range that we can see. We also know that kidney disease can greatly increase morbidity in pregnancy and also affect fertility, especially for those who have those higher stages of kidney disease, like 3 through 5. And these patients also have higher rates of things like early miscarriage, reduced fertility, increased risk of preeclampsia, and further kidney damage in pregnancy, which is why it's something that I think it's important that we know about and we talk about. But I think before we go any further, I feel like I've kind of put the cart before the horse here because I've started already talking about the stages of kidney kidney disease. So let's kind of take a step back, since I'm sure, most of our listeners are not nephrologists. Let's kind of go through what exactly the stages of kidney disease are.
Yeah, so you may kind of remember or see in your electronic medical record when you order kidney function tests, getting a result back that says eGFR, the estimated glomerular filtration rate. And the stages of chronic kidney disease are basically paired together with a range of eGFRs. Now, these GFRs, we should mention, are calculated values. There are a variety of ways to calculate values. This has been an area of controversy in nephrology, and we are not going to dive into that controversy today. We are just going to label the categories as they exist, and how you will encounter them when you're looking at the assessment and plan of somebody with chronic kidney disease. So stage 1 chronic kidney disease is kind of the normal or mildest, and this is any eGFR of 90 or better. And again, this is normal kidneys or just very mild kidney damage, and basically the kidneys in this stage work well or almost as well as normal. You may have some signs of kidney disease in this stage, such as proteinuria or a slightly elevated creatinine, but not anything super significant or impairing life function. Stage 2 is the next down, and that's an eGFR of 60 to 89. Again, this is just considered mild kidney damage. Then stage 3 gets broken up into 3A and 3B. So 3A being the upper part of this next 30 iteration, 45 to 59 for the eGFR. And stage 3B being an eGFR of 30 to 44. So this is spanning kind of this mild at the upper end of 3A with an eGFR in the high 50s to fairly severe as you get to 3B and kind of an eGFR in the low 30s. Again, but it's divided out into 3A, 45 to 59, and 3B, 30 to 44. Then stage 4 is an eGFR of 15 to 29, and that is severe kidney damage. And then stage 5 is an eGFR that's under 15. This is obviously the most significant, and this is typically hemodialysis requiring, so that type of severe kidney damage. Okay, so we've labeled, Fei, stages of chronic kidney disease, so that way if you see it in the medical record, you can kind of link and be like, okay, this is severe, this is not so severe. But pregnancy is different. And so before we go any further, again, before talking about disease in the kidney, let's just talk about what pregnancy does to the kidney.
Sure. Yeah. And so if you want a full review of this, I would encourage everyone to go back to one of our first episodes titled Physiologic Changes of Pregnancy. We will post a link to that on our website and in our show notes, so you can go back and take a look. But to summarize, during a healthy pregnancy, kidneys actually increase the production of erythropoietin, active vitamin D, and renin. There's also an increased renal blood flow, which leads to an increase in glomerular filtration rate of more than 50%, which then leads to a relative decrease in the concentration of things like serum creatinine and urea. So values that are considered normal in a non-pregnant state may actually be considered abnormal or elevated in pregnancy. We'll put this nice graph on our website to show you the increase in mean renal plasma flow and GFR in pregnancy. And we'll basically show you how much it increases from prior to pregnancy to the first, second, and even third trimesters in pregnancy. And this is kind of lifted straight from some of the data that Williams shows. So I think one of the things, though, that we incorrectly think is like, hey, so if there's more blood flow going to the kidneys during pregnancy and your GFR is actually increasing, shouldn't that actually be good for the kidneys, Nick?
You might think it. And again, the astute listener might have thought, well, gosh, an eGFR, it was 70 and now it's 90. Like, so isn't that good? Did the kidneys get better? And the answer, unfortunately, to that is no. And you have to think about the fact that the kidneys in this case do have disease. So folks with CKD, even if that number kind of artificially goes up, are less able to make the renal adaptations needed for a healthy pregnancy. So for instance, patients, again, with intrinsic renal disease, you might not be able to boost your renal hormones to the same level as somebody without kidney disease. And so these patients may be more prone to things like normocytic anemia, reduced expansion of their plasma volume ultimately, and vitamin D deficiencies, and kind of diseases that can be contributed to from that. There's a gestational age rise in GFR that's blunted in those with moderate renal impairment and usually doesn't occur at all in those with a serum creatinine of worse than 2.26 milligrams per deciliter. So fairly high. But again, even though you might see that rise in GFR in some folks with mild kidney disease, as you get more severe, this actually gets blunted entirely. And so it's not that the kidney disease is necessarily getting better. It's just that some folks might have some physiologic reserve and other folks might not. Okay, but 2.26, Fei, if I saw that, I'm starting MAG, right? Sorry, no, bad joke about preeclampsia. That's a fairly high creatinine, though. So do people with better creatinine or better GFRs have much to worry about, I guess, is my question here when it's better than 2.26?
Yeah. So, I think one of the things that we often counsel our patients about is how does pregnancy affect a certain organ if there's dysfunction to begin with? So how does pregnancy affect the kidneys if there is, first of all, mild renal impairment versus moderate to severe renal impairment? So in those with mild renal impairment, they may not have a significant impact on their future renal function if they were to get pregnant. And in one study of 360 women with primary glomerulonephritis and mild renal dysfunction with a creatinine that was elevated but less than 1.24 milligrams per deciliter and minimal proteinuria, meaning less than 1 gram per 24-hour period, and they had absent or well-controlled hypertension before pregnancy, these patients actually had little or no adverse effect in terms of their long-term renal function. But the story is actually very different if the patient has moderate to severe renal impairment. And so in this area, of course, I first want to say that there isn't a lot of data, and most of the data is coming from small, uncontrolled retrospective studies, mostly because you can't really tell people who have moderate to severe renal impairment, hey, you get pregnant, you don't get pregnant, right? But basically, these patients who have worse renal function before pregnancy are at greater risk of an accelerated decline in their renal function during pregnancy. And especially for those who have moderate renal impairment, meaning defined as a creatinine of somewhere between 1.4 to 1.9 milligrams per deciliter, these patients had a 40% risk of decline in renal function during pregnancy, which then persisted after birth in about half of those affected. And in those with severe renal impairment, those who had a creatinine of greater than 2, 65% had a decline of renal function during the third trimester, which persisted in most women and deteriorated potentially even to end-stage renal failure in 7 out of the 20 patients that they looked at. And those with both an eGFR of less than 40 milliliters per minute and proteinuria greater than 1 gram before pregnancy showed also an accelerated decline in renal function during pregnancy. Okay, so I think that's, one thing that we always talk about, I think when we talk to our patients, is how does pregnancy affect a certain organ? So let's flip that now. How does kidney function and chronic kidney disease affect pregnancy, Nick?
Yeah, I think that's a really fascinating question, Fei. And it's the same paper you had pointed to earlier about how pregnancy affects renal function helps us to answer this question about how renal function affects pregnancy. We'll post a table from this paper on our websites talking about pregnancy outcomes vis-a-vis somebody's pre-pregnancy serum creatinine or their baseline creatinine value. But important to highlight is that in patients with a creatinine of 1.4 mg per deciliter or higher, it seems like this is where more complications begin to occur, both for mom in terms of the renal function decline, as you mentioned, as well as for the baby. And these are for things, as we see concerns about fetal growth restriction, preterm delivery, the rates of preeclampsia, and even the rates of perinatal death, all start to climb as you get above a creatinine of 1.4. Now, qualifier, this is data and estimates from 2008. Things have changed in kidney disease and the management of kidney disease. And so the numbers may be better now for some patients, frankly. But I think this is a good starting point in terms of counseling and in terms of just expectation for the course of the pregnancy. So that way you know what to expect as you co-manage these patients with your nephrology colleagues. So again, these risks, Fei, if we look at them, for patients who have a creatinine of worse than 2, if we just take it there, right?
Yeah.
Incidence of fetal growth restriction, according to this series, was 65%. The rate of preterm delivery was 90%. The rate of preeclampsia was 60%. These are like pretty significant risks. And so one thing I think that we have to ask as a podcast catering for the general OBGYN is, are these things that I can hopefully managed by myself by a general OBGYN, or should I call my friends?
Yeah, absolutely. I think in these patients especially, don't worry. You should definitely consult your friendly neighborhood maternal fetal medicine specialist and your nephrologist, who I think would be more than happy to co-manage these patients with you and talk to them, especially in the preconception period, to talk about possible outcomes, what they can do to hopefully make those outcomes a little bit better. So let's break that down in terms of before pregnancy. So I think, we talked about all the risks already, but I think it's really important to counsel your patients about those specific risks that are related to their kidney function, because sometimes patients don't realize how significant those risks are, and they may choose to either not become pregnant, or they want to do something to hopefully improve their kidney function, to hopefully improve their perinatal outcomes. If they don't want to become pregnant, make sure that they have appropriate contraception to avoid pregnancy. But if they do desire pregnancy, this would be a reason to discuss with their nephrologist or other medical specialists about how to improve their kidney function. And for some people, like those who are on dialysis, this may actually mean getting a kidney transplant and being stable with that kidney transplant before planning a pregnancy. As with anybody who wants to get pregnant, I would recommend starting folic acid, 400 micrograms daily at least, and then also discussion with their other providers like their nephrologist or, primary care doctors about their medications. A lot of these times, these patients who have kidney disease also have hypertension. They may be on medications that are not compatible with pregnancy, so things like ACE inhibitors and ARBs and other things. And so really a conversation about how do we transition these patients off of these medications, but also make sure that they are then going to be stable on a different type of medication that is compatible with pregnancy. So what about in pregnancy? I mean, we OBGYNs certainly still have to do a few things for these patients. So what would you recommend to your patients who then become pregnant with their kidney disease, Nick?
Yeah, so as we mentioned, one of the main significant risks with renal disease and pregnancy is the risk of hypertension, specifically preeclampsia risk. And so these patients should certainly be counseled about starting low-dose aspirin approximately 12 weeks gestation or earlier, and also to be checking their blood pressures. They should be familiar with how to use a blood pressure cuff. They should have a cuff that they're tracking blood pressures with. And for you, in terms of goals, trying to keep blood pressure within normal limits and make sure that we are checking those at every visit is really, really important, because if there is evidence of chronic hypertension that's very frequent in this population, we want to try and jump on that earlier, right? As we've talked about things like the CHIPS and CHAP trial on the podcast before, it seems that earlier control is better control for pregnancy outcomes. Additionally, in terms of the beginning of pregnancy, we want to talk about sort of laboratory checking. So from a serum or blood work type of thing, we want to check a CBC, and we want to look for signs of anemia, right? Again, erythropoietin, if it's not being produced, may result in a normocytic anemia that is particular to these patients. We also want to look at chemistries and establish what baseline renal function is if we're not totally certain. Again, creatinine, BUN, and probably check those periodically through the course of the pregnancy to see if we're kind of having a normal rise in that GFR or if we're having that blunting effect in particularly severe kidney disease. Checking the urine is also very important. Again, these patients, you don't want to box their kidneys any further than they're already boxed, right? So being aggressive in terms of evaluating for signs of asymptomatic bacteriuria or urinary tract infections to prevent pyelonephritis. And you're also wanting to get baseline evaluations for things like proteinuria and hematuria, right? Just to know where you're standing and if the kidneys are getting stressed by pregnancy, if that's starting to worsen. Speaking of proteinuria, one thing that comes up frequently in conversations surrounding these patients is the role of thromboprophylaxis with low molecular weight heparins. Again, when you have so much protein spillage, you're going to be spilling some of those anticoagulation type of factors. And so these patients live in an even more procoagulant type of world than our usual pregnant patients. And so there have been varying cutoffs proposed for this, but kind of the more common ones that you'll see in the literature suggest considering thromboprophylaxis if you're exceeding 1 gram of proteinuria in a 24-hour period. Okay, Fei, that was a whirlwind through the world of chronic kidney disease. Why don't we try and summarize super quick?
Sure. I think we first started talking about the prevalence of chronic kidney disease in our population, which can be as high as 3% in those of childbearing age for stage 1 to 2, and then even 1 out of 150 with those with stage 3 to 5 kidney disease. We then talked about the fact that kidney disease itself can greatly increase morbidity in pregnancy and affect fertility. And then we've talked about the different stages of kidney disease, going from stage 1, which is normal or mild kidney damage, all the way to stage 5 with an eGFR of less than 15, which can be severe kidney damage that requires dialysis.
Remember that in a healthy pregnancy, the kidney has a vital role. It increases production of erythropoietin, active vitamin D, and renin. There's increased renal blood flow, increasing the GFR by more than 50%, and that leads to a relative decrease in concentrations of creatinine and urea. And so again, we'll post on our website sort of the really impressive graph establishing how renal blood flow changes during the course of pregnancy. What that means, though, is not that the kidneys get better because of all that increased blood flow and a potentially elevated GFR. Folks with CKD are less likely to make those renal adaptations, and so they may suffer from things like normocytic anemia, inability to expand plasma volume, vitamin D deficiency, and they may not even get any rise in GFR if they have particularly severe renal impairment, usually with a creatinine of around 2.26 or worse.
In terms of how pregnancy can affect kidney function in the long term, those with mild renal impairment, meaning that their creatinine was less than 1.24 and minimal proteinuria, did not necessarily show long-term adverse effects on their renal function with pregnancy. However, in patients with moderate to severe renal impairment, especially those who had creatinines greater than 1.4, there was actually a significant number of patients in studies that have shown that they have a decline in renal function during pregnancy, which then persist after birth.
In terms of how kidneys affect the pregnancy, there are increased risks of a number of things in pregnancy for folks with CKD, including rates of fetal growth restriction, preterm delivery, preeclampsia, and perinatal death. These risks seem to pick up at a creatinine of 1.4 mg per deciliter or worse. And again, we'll post that data on our website from the Williams paper that Fei mentioned.
With regards to how to manage these patients, it's totally normal to consult your neighborhood maternal fetal medicine specialist and also your nephrologist. It's important to counsel these patients before pregnancy about the risks that we've previously discussed, give them contraception that's appropriate if they don't want to become pregnant, but then also discuss with them and also their other providers on how to best optimize them, especially with medications before pregnancy. In pregnancy itself, things to consider is to start a low-dose aspirin at approximately 12 weeks gestation, checking their blood pressures and maintaining their blood pressures, less than 140/90 if possible, checking lab work like CBC and renal function, and checking urine for things like urinary tract infections, proteinuria, and hematuria. And finally, consider giving thromboprophylaxis in those who have proteinuria greater than 1 gram per 24 hours. All right, Nick, I think that brings us to the end of this podcast. So once again, this is Fei.
This is Nick.
And this has been CREOGs Over Coffee.
So guys, if you enjoyed the podcast, head over to iTunes, Spotify, Google Play, whatever your podcatcher is, give us a 5-star rating and review.
You can find us on social media on X at CREOGsoverCoff1, on Facebook and Instagram at CREOGsoverCoffee. And if you want to donate to the show, go ahead and go over to our Patreon at www.patreon.com/CREOGsoverCoffee.
You can find show notes for this episode and all of our previous episodes on our website, CREOGsoverCoffee.com.
And if you want to reach out to us, have a question about the show, have ideas for an episode or a correction for us, go ahead and email us, CREOGsoverCoffee@gmail.com.